really don't. We go over it like once a year during refresher. We go over it now, but we really don't talk about trauma triage, how to handle an MCI, how to tag these patients appropriately, and then what do you do with them afterwards. Trauma triage is really just like the initial part of this giant MCI. We have our all hazards response. We have multiple agencies getting involved, but there's this thing called triage that has to get done, and we all are holding on it because we don't do it nearly enough, myself included. So the objectives are we're going to kind of discuss the need for trauma triage, go over what SALT triage is, and that's what the state has us using right now. For pediatrics, it's technically Jumpstart, but we can use SALT for all ages to make it work. We're going to understand triage categories, and then we're going to perform triage on simulated casualties, which is that paper in front of you. And those of you kind of streaming in, we'll make this available to you as well, this triage sheet. So first of all, what is a multiple casualty versus a mass casualty? And this is coming from Vermont State Protocol. And a multiple casualty, it's got 2 ambulances going, and there's like 4 patients, and 3 of them you can all put in one truck. 1 patient's a red. Is that really a mass casualty? Does that exceed our resources? No, it doesn't. Because we can treat life threats first, but our number and severity don't exceed our ability to take care of them. It is only a true mass casualty when the number of patients and the severity do exceed our capability. So coach bus, Greyhound bus rolls over 91. Would that overwhelm our station? Exactly. It does depend on the number of people. But yeah, generally, a fully loaded school bus would overwhelm our capacity. Unless they're all green. If they're all green, mass casualty cleared, mass casualty done. Pretty much that fast. Then it comes to where we're going to relocate. But treatment is geared towards patients with the highest chance of survival. And this is where we're all bad at it, because we look at someone who's acutely sick, someone who's barely breathing, and we want to treat them. We want to help. We want to do right by that person and recognize them as being critically ill. And we don't want to say, you're probably not going to make it. We're going to bypass you. That's a very difficult call to make. It's not an easy call to make. So case number 1, you're on scene for a coach bus rollover. You've got multiple patients lying in the road, 1 patient protruding through the bus windshield, unknown total occupants. You hear screaming, you hear yelling. Your supervisor is 10 minutes away. Initial response is 2 ambulances, one is at the paramedic level, one's at the advanced EMT level. What are your initial actions? What are your thoughts?
Stabilize the scene.
How? How are you going to stabilize the scene?
Personally, I would start going, like we have patients laying in the road. Start going through seeing what we have for injuries with those patients.
How about you backstep about 6 steps and block the entire roadway? Secure your scene. Like, make sure that you're safe. Like, if they're lying in the road, you're not going to go ahead and like start moving them immediately. We're going to want to try and make this your scene, own it. To go back to scene safety BSI, you see 18 patients, you want to go help. So we really need to kind of keep in mind, we're going to keep our scene safety first. But yeah, then start assessing that. So who does the initial triage? So based on that, multiple patients, you can say more than 4. You look at the scene, you see out, in your mind, you think a lot. You think that's a lot of people. When would you call it? Yeah.
You start getting resources coming, because it's better to have them coming and cancel them than need them and not have them there.
Absolutely. Let's get the resources coming, put out the mass casualty. And our flip books in the trucks that actually has the mass casualty, the MCI plans. So it determines the number of patients, determines the level of MCI. So like a level 1 MCI is 5 patients. Between 5 and 10 is an MCI level 2. Level 2 MCI automatically gets 1 helicopter. Level 1 MCI is all managed in-house. It pulls all D1 ambulances, all D2 ambulances. That's part of our MCI plan. Level 2 pulls in total of 10 ambulances plus 1 helicopter. And then the level 3 pulls in 2 helicopters and 20 ambulances. So depending on how many patients you have, we can start working down that you can call up dispatch, say, yeah, give me a level 3 MCI, give me a level 2 MCI. And now, should that be a you call, or should that be your supervisor call? Yeah, and that's why I put this part in here. You want a supervisor coming to that scene. When they get there, where are you going to put them?
Operations.
Yeah. Hey, Zach, I know you're here. I need you to stand there and manage stuff, manage people. I've got all these resources coming in. Have him liaise with the fire departments, find out if that vehicle can be moved or not, where we're at. But really, like, our providers need to be, you're going to put Zach under EMS command. And then from there down, we're going to start filling out our own roles. So who should do the triage?
Isn't a triage a basic skill?
Triage is an EMT skill, absolutely.
That way you can leave your medic and your A to take care of your criticals.
Yep, absolutely. I'm not looking for a green EMT. I'm looking for an experienced EMT, because you're looking at people saying, you're going to die, you're not going to die. So it's a tough call to make. You don't want someone who's fresh and green making that decision, because they may hesitate. Our goal is 15 seconds. I come across a patient, I've got 15 seconds to make a triage determination. Are they green, yellow, red, black? And move on. We should have it down to like about 10 seconds if we're good. That's why there's literally 28 patients on those handouts, because we're going to go through and triage a bunch of people. So initial, we don't treat. This goes against everything we know. Come on a cardiac arrest, what's the first thing you do? On a cardiac arrest, what's the first thing you do? Start CPR. You start doing shit. We're going to limit our interventions. We're going to do tourniquets. We're going to do bleeding control. And we're going to open an airway. That is it. And step 1 is open that airway. Tourniquets on, open the airway. If they're not breathing, we're going to move on and call them dead. Triage is always fluid and cyclic. It never ends. And this is where EMTs are commonly taught wrong, is that with trauma triage, they say, this is your triage, and they phrase it as an end. There's no end. You get down, so you start triaging your reds. You go to people that can't walk first, start triaging your reds. You get them triaged, and you're moving on. But when you get down to your greens, you're actually going to go back to your expectants and your reds and re-triage those as you go through. The person doing triage is always re-triaging. You're always changing colors. For example, you have Scott over here. He's part of this crash, this incident, and his arm is completely cut off. He's got spurting blood coming out of his arm. What's his category right now? It's probably red. He's bleeding. He's got uncontrolled hemorrhage. He's a red. Sierra, being the smart EMT she is, puts a tourniquet on. What is his category now? Yellow. And now let's say Scott goes unresponsive. Where's he now? Red. He's still breathing. He still has got carotid pulses. So it can change that quickly, that you go from red to yellow to black, or red to yellow, back to red, maybe to black. Maybe he gets, his belly starts distending, and you're like, yeah, we don't have the resources to manage him. You black tag him. You treat people that you can save, that you think you can save, and then you come back to him, and then you'd re-triage him as a red. So there's always re-triaging that's always happening, that kind of we forget about. In our mind we're doing it, but we're not actually physically doing it, but it is always happening. So these are our wonderful triage tags, and I tend to use gray and black interchangeably. On our triage tags, they are different. There is a gray tag, there is a black tag. So start with the reds. Kind of stands out at you. Immediate life-threatening injuries. And on your truck, just play with the origami. It's horrible. But red is life-threatening injuries. Yellow is delayed, so they need surgery, more or less, but they can wait a little bit. So they're serious injuries. A lot of us think yellow is like minimal injuries, minor injuries. No, yellow is serious injuries, but they can wait. And then green is minor injuries. Grays are not dead. And remember that. Grays are not dead. So when you're coming back to triage, target your grays. They're not dead yet when you initially triage them. They may be now, but they were not dead when you tagged them. And they're unlikely to survive given the resources we have. So things like burns to 90% of their body, radiation injuries over 24 hours old, and they're nausea and vomiting. They're not going to survive. And then black is pulseless, apneic. They're dead. First thing you do, hey, who can stand up and walk to that tree? Who can walk over to that EMT with that bright, shiny vest on, standing over there? Have them walk over there. Take one EMT, say, you're on greens, triage amongst the greens. If they can walk, they probably don't have any serious injuries. They might, but we're going to triage them. Hey, who can wave? Have them wave, and you're going to go to everyone that's not waving. They're still. They fit into one of two categories. They're either dead, expectant, or a red. They can't move. So that's how you're going to do your initial triage, is you're going to do global sorting. Everyone who can walk over there. Everyone who can wave at me. And you're first going to go to everyone that can not do anything. Then you're going to go to people who are waving. And then finally, if you have enough people, just assign, hey, Sage, you're going to work on everyone that's waving. Hey, Scott, everyone that's walking over to that tree, go over there and triage them. Hey, Megan, everyone that's not moving, go to them and start with them. And then now you're handling 3 triage categories all at once. Megan just sees one piece of tags. Megan knows she's like handing out red tags because they're red or they're black. You hope they're red.
There's going to be some crossover on that, especially like, hey, can you walk over here? And there's like a couple, and he helps his wife over there with a serious injury.
Exactly.
Gets over there, or people that aren't actually listening, paying attention to us. Hey, can you wave your hand? They don't wave because they're not listening to us, not paying attention.
Exactly.
For that as well.
No, absolutely, for sure. There's always crossover, and that's kind of why you assign, if you're having them walk somewhere, send an EMT with them because you're going to do initial triage within that group. Because there may be some yellows, like Jason said, that kind of filter into that group. Non-typical sorting. Is a school shooting conducive for that type of global sorting? No. So how do we do schools? How do we do these large-scale events that are in buildings? Yeah. You see them, you triage them. And quite honestly, if they're a green or a red, I'm tagging them and I'm moving on. If I tag a green, okay, he's a green, no big deal. I've got a guy with bleeding out of his arm. Put a tourniquet on it real quick. You got like a couple seconds. Put the tourniquet on. He's now a yellow. Cool. Move on. He's a yellow. Are you that concerned for the right now? No. They're breathing. Their bleeding is under control. Now, if they're red, you might want to consider looking at, as part of the rescue task force, the officer saying, hey, we're moving this one back. Or breaching into a room and taking over a room as like an intermediate casualty collection point. But as we deal with these schools, these office buildings, these mass shootings that we're all training for, that we hope never happens, they teach us this global sorting technique, and then they don't teach us how to actually handle it in a school because it's not going to work. It's a different environment. You have to treat what you see first. If it's a green, it's a green. You tag it and you move on. If it's a yellow, it's a yellow. You tag it and you move on. If they're black, keep moving on. If they're expectant, move on. Only if they're red am I actually going to try and pull that person back at that point to a casualty collection point. Yeah.
Part of our in our kits, we have Sharpies and white concrete next to every door. We're going to sort of by room right in the doorway.
Yep.
Green number of people, red number of people. Whoever's coming in afterwards, no, okay, I got no reds or blacks here. I can move on to the next round.
Right.
Secondary triage.
Right. If they're reds, we should be trying to do something for reds, but I mean, in theory, we've got a lot of people here. We're going to be working room by room by room anyway, and like these things move fast. Like when I say you've got 5 seconds to triage an individual, you've got 5 seconds to triage an individual, and we'll make it simple. So then we're doing our individual assessment, and this is not a detailed trauma assessment by any stretch of the imagination. Are they breathing? Quick and easy. If the answer is no, they're dead. You open the airway, nothing happens, they're apneic, they're dead. They're agonally breathing. That classifies as not breathing, they're dead. Move on. Do they obey commands? Do they have peripheral pulses? Are they in respiratory distress? And is bleeding controlled? Or are they not in respiratory distress? My bad. If the answer no, it's will they survive? So if they don't obey commands, they don't have peripheral pulses, they are in respiratory distress, and hemorrhage is not controlled, if they will survive given the injuries, for example, an arm amputation, they're red. If no, they're expectant. So if they've got multiple injuries that you're looking at, you're like, I don't know even where to start, they're probably a gray tag. That's kind of my determination is I look at them and in my mind, I'm thinking, well, where do I start with this one? That's probably injuries incompatible with life. Should probably put a gray tag on and move on. Or they have exposed brain matter. Exposed brain matter is also going to be probably a gray tag. You don't have the resources to manage that. They need neurosurgery now. They're not going to get that. We should gray tag them, move on. If they're still alive later, then we can work on them. If all are yes, are there only minor injuries? Minor injuries are abrasions. That's about it. Abrasions, small lacerations. Can they walk around? Are they relatively non-injured? That's minimal. If they're delayed is if there's not minor injuries, but they've got they obey commands, they have pulses, they're not in respiratory distress, hemorrhage is controlled, and they have some kind of significant injury that's not just a minor abrasion, they're a yellow tag. A lot of patients inadvertently kind of fall into this yellow tag category because they may have broken arms, and they'll kind of fall into this yellow category. During the assessment, we should be performing life-saving interventions. This is a head tilt chin lift or jaw thrust. Maybe slap an OPA in there because you can't maintain that. Control gross hemorrhage. Put on those tourniquets, whatever it takes, get the bleeding controlled. If you don't control the bleeding, you're going to die anyway. Open the airway. Medic should be doing chest decompressions. If there's an obvious tension pneumothorax, unilateral chest rise, respiratory distress, and no jaundice sniffle exam, they should be doing a chest decompression now, or they should be using an occlusive dressing now, because that will kill them in the next 5 minutes. Also, auto injector antidotes, which we don't really carry those. That'd be like your duodote, your 2-PAM chloride, your pralidoxime, all that stuff for those nerve agents. Yeah, it's up.
In this situation, if we're going into that, are we expected to have a handful of stuff? Or do we have bags that we're going to be carrying with us? Because like we're talking about putting tourniquets on people,
Yep.
having OPs and NPs on us. So
We have our trauma we have our trauma kits, and in those
Big backpack with a bunch of those.
we've got NPAs.
Backpack on.
I didn't even
Yeah, so we've got NPAs, tourniquets, chest seals, bleeding control. So we've got the combat gauze to pack wounds, and we also have tourniquets. There's a Sharpie in there, and the ones that are paramedic level have chest decompression needles.
And the medic levels are the red ones or the.
Gray, tan ones are medic level. So grab one, grab a couple.
So we go into
Black, grab the big black bag and grab the body armor. Grab your body armor. Then grab the yellow bags too. So the yellow bags are for our casualty collection point. So when we first get to the scene, I'm gonna look at Jason, toss him 4 yellow bags, and say, set up the CCP, get ready for incoming patients. And he's gonna get stuff ready for us. And then that way he's managing that. He's now CCP commander. Ultimately, to probably come back and be a senior medic, taking that over from him. But he's setting up stuff so that when we roll patients into that casualty collection point, before we get ambulance there to evacuate them, things are ready. We're setting ourselves up for success to have a treatment area that's ready. So basically what we're doing for initial triage for red is, are they in shock? That's kind of the standards. Are they in shock or not? And if there's absent peripheral pulses and present central pulses, they're in shock. If they have difficulty breathing of any degree, they're considered to be in shock. If they're unresponsive, they're in shock. Burns over 20%, less than 80%, they're in shock. And if they're confused, they're also in shock. These are really the things that make a red patient. These are what makes a red. Because uncontrolled hemorrhage, that's really a misnomer because we have stuff to control that bleeding. We should be controlling that bleeding when we get there. So immediates, these are our reds. Gross hemorrhage, absent pulses, respiratory distress. This is down that line of attention pneumothorax. If they have nerve agent exposure and they're seizing, they're a red. If they're not seizing, they're not a red. If they're unresponsive, burns greater than 40%, less than 90%, or burns to any sensitive areas, hands, feet, neck, groin, circumferential chest. These all make a red. And these aren't covered in SALT triage. They don't care about burns. But we all know that burns are significant. If you get even multi-occupant house fire, where this might apply, now you've got to deal with just burns. And these degree of burns are going to determine air medical transport for 1, and they're determining your triage category for 2. Because if the burns are less than 20%, we don't care about them. If they're 90% or over, or even over 80%, you can justify 80% as well. They're probably not going to survive. Ray tag them and move on and come back. If we have penetrating chest trauma with respiratory distress, they have to have trouble breathing with penetrating chest trauma to be considered a red. Just because they've got a giant hole in their chest and they're breathing just fine does not mean they're a red. Just because their organs are all hanging out doesn't mean they're a red. They have to have signs of shock. Pelvic fractures. Those are reds by the very nature that they can bleed out. They'll be fine 1 minute and not fine the next. So if you're suspecting an open pelvic fracture, there's a lot of vasculature in there. They will die very quickly. We have to take steps to get them to surgery. And then altered mental status would also bump them into that red category. So, common question, what if they're drunk? What if they're stoned? Discrimination. If you think that they're altered because of some other substance, then maybe don't tag them as a red. But if you can't rule it out, tag them as a red, figure it out later. So, okay, we have 36-year-old male, it's non-ambulatory, unresponsive, absent radial pulses, present carotid pulse, abdominal bruising with normal respirations. What's the triage category? And why is this patient red? Yep, it's the augmentation. We've got absent radial pulses, and they're unresponsive. We had 3 criteria right there for red. And the abdominal bruising makes us think that there's internal bleeding, but it doesn't really play into our triage decision. Present carotid pulse really just quantifies that they have a pulse, period, and they're not dead. If there's no carotid, tag them black. Our delayed patients, the bleeding that has been controlled. Doesn't matter where it's at. I can't really control that. They need surgery. But if you can control this extremity injunctional, this compressible hemorrhage, tag them yellow. Amputations, bilateral abdominal amputations. If it's on both legs, those are serious injuries. They just lost both their legs. That is controlled. We're not worried about it anymore. They need surgery, but they can wait. They're not going to die because of other causes. Long after delay, burns greater than 20 but less than 40. So they're burned a little bit. They need fluid, but they're not going to die because of their burn right now. Abdominal eviscerations without hypotension. That signs of shock, that present radial pulse we're looking for. So yeah, their guts are hanging out. More sterile dressing and kind of move on. But they're going to die right now. And some necrotic bowel, maybe a lot of necrotic bowel, openly exposed to the air, but not going to kill them right now. If they had minor nerve agent exposure, so they're not seizing, and they've had nerve agent exposure, then they're delayed. If they're oriented, they have to be oriented to be delayed. Altered, they're red. So 71-year-old female moving their arms, because I know quantifier that they're global sorting, they're the second priority to look at. Open chest injury. Rise and fall of the chest, and they say, yeah, my chest hurts a little bit. What are they? They were delayed. This part here scares every living Jesus out of us. It's open chest injury. We're like, they need surgery now. Just fine. And then minimal. They didn't require hemorrhage treatment. Minor lacerations, abrasions. They have peripheral pulses, or you can refill. Normal capillary refill will work just fine too if you can't feel a pulse, because some people have a hard time anyway. There's no shortness of breath. Bleeding is controlled. They follow all commands. They're oriented, and also burns less than 20%. Minimal. So 18-year-old male walking around, second degree burns to both arms, no involvement of the hands. Green. What would it be if his hands were involved? Yeah. Yes, that's Bavaria. Yep. So we're not just thinking, will they survive the next 24 hours? We're trying to think when we're triaging these people. And that's why we put burns in there the way that they're put in there, because we're looking at how well will their survival be? Like, what's their quality of life? They don't have hands. Really, like, what's the quality of life there? Pretty low. And now we've got our bags, our heads, pulses, peripheral and carotid. No breathing, opening an airway. Black tag. Medic should be decompressing both sides of the chest before you tag someone black, if it's possible. Absolutely. If you're not a medic, you should tag them and move them. But if they're a medic, they should be decompressing the chest before they tag someone black. Before they stop resuscitating, they should tag them. They should decompress the side of the chest. 32-year-old female, non-ambulatory, penetrated chest trauma, non-responsive, absent pulses. So our expectants. This is where things get hairy. This is where things get confusing. This is where things get not generally comfortable for us. They're not likely to survive. Exposed gray matter, agonal breathing, absent peripheral pulses, burns over 80 or 90%, and radiation exposure in the past 24 hours with vomiting. 2-year-old male, non-ambulatory, doesn't sound fun. Eviscerated organs, quadruple amputee with pulsal hemorrhage, and penetrating chest trauma. Do you want to work that kid? What does your instinct tell you to do? Instinct tells you to work the kid. And this is where things get uncomfortable. We need to make a decision whether we're going to work this kid or not work this kid. And with these injuries, we really shouldn't be working this kid. We should be tagging them gray and moving on. They're not likely to survive with the current resources unless there's a surgeon right there. Gray tagging is not comfortable. Gray tagging is not comfortable at all. Shades of gray. What do we do for these patients? What do we do? They're not dead, but we're tagging them and treating them as if they are. Comfort care. Take your most experienced provider and stick your most experienced provider with them with a lot of narcotics. Death with dignity, comfortable death, and pain, we're going to treat the pain. Make them as comfortable as we can. And this is where like gray tag and I hate the gray tag because as it's a black, everyone tells us treat it as if it's a black, and we leave them. We do a great tag and we leave them. They're still alive. We shouldn't just be leaving our gray tags. We should be consolidating them, putting them in a location for re-triage, and there should be an experienced provider with them or whoever comes around to identify, okay, we've got enough resources now. This guy's now a red. And we should be doing that re-triage. Gray tags are not fun. How we handle them is kind of what we need to do. They're still people. They're not dead. We need to stick experienced providers with our gray tags to appropriately manage them, comfort them. There's clergy around on instant that side, they may end up being there at some point. Get them over to them. We are saying that this person is not going to survive. That's what we're doing. It's a decision to make. And what about all these people at once? Sage has now come across 4 recommendations to treat all of them.
Go Sage.
We're going to do an algorithm. Whatever you want. You're controlling bleeding first. That's the big thing. You control bleeding first. But you're going to go around and control bleeding on all of them. Your way on all of them. And you're going to go in a circle. You're not going to do a whole assessment on one person. You're going to do one thing on each of them. And you're going to work in a linear fashion or a cyclic fashion if you want to look at a circle. You're going to do everything to all of them all the way down.
As long as they're within close proximity.
Move them. That's why we have a casualty collection point. We should be having a casualty collection point and moving these patients to the casualty collection point and then sorting them there by triage category. That way we can actually, I can say, hey, Jason, you're on yellows and you've got your area. People are bringing in yellows and you just line them up and you work them. Because if you just do all of this on one of your reds, well, turns out the next guy over needed an airway, needed an OPA, and you didn't do it because you were busy bandaging a head wound, and they died. So do hemorrhage on everyone, airway on everyone, respiration on everyone, kind of in that fashion across the manner. What about hazmat? How do we handle this? Hazmats are gray. And going back to the shades of gray, within the shades of gray, you essentially have your priorities because you know within your grays who's going to survive and who's probably not going to survive. So whoever's most likely to survive but needs the most treatment, they're going to get decon first. But only simple treatment can be performed during decon when we're all in protective equipment. We can't intubate them. We can't cryotic them because now we're just getting all that hazmat exposure inside their body. We can't really do any invasive skills. We're stuck to simple skills. So when we add this hazmat level to it, it's a whole different level of triage. They kind of exist in a subset of their own, and they need to get triaged independently of the major incident. That would not be fun. That'd be a lot of moving parts. And they get deconned. And even when you're deconning, you got to figure out who is the most likely to survive. Especially if there's a significant hazmat incident. They've got acid burns over, I don't know, 90% of their body. They need decon, but they're also probably not going to survive. So of your expectants, they're the expectant of the expectants. Or you have someone that's contaminated, but they have some chest trauma with difficulty breathing. Well, they're red. They're your red of your grays. If you go about it in this way, that way we treat the people the right way and we get them deconned appropriately. Questions, thoughts? People that are tuning in from home, feel free to send me a text. Questions? Thoughts? Cool. Now we're gonna practice. I'll have that sheet in front of you. And for those of you at home, I'll throw it up on the screen.
So this is actually thing that we can listen to as well.
Yeah.
What do you say? Yes, you did.
So first is the 12-year-old female, non-ambulatory. With penetrating trauma to the chest, absent radial pulses, and they state they can't breathe. Red. Yeah. There should be a bunch.
Two for the last two. Do you want me to go like a copy?
Nah, I've got a bunch right here. You're welcome.
Hold it out.
Sorry. Okay, now we've got a 36-year-old male waving their arms. Abdominal injury with eviscerating organs, radial pulses present, states he's in severe pain.
Yellow.
He can't walk, he waves his arms.
Yellow.
Yep. And what makes it what makes him a yellow?
Radial pulses. and he's
Present radial pulses, he's talking. Yep, that makes him a yellow.
The ABCs that are present.
They are. And I have a 22-year-old female who's ambulatory. Second degree burns to both hands with radial pulses.
Red.
Red. Next one.
Green.
Green. What?
TD issue.
Yeah. And what about black or the next one? Second row, first one. Yeah, you can gray tag him. You can black tag him. Either one works. Next one.
Red.
Red. 42-year-old female.
Yellow.
Yellow. Yep. 20-year-old male.
Green.
Green. Yep. What about the next one? The 30-year-old female.
Red.
Torso, back, both legs, including genitals and arms. What's that body percentage of burn?
Black.
I go gray. Yeah. Amanda said gray. Well, and that's a 28-year-old male who's screaming.
Tourniquet and they're yellow.
What are they right now, though?
Red.
Red. Exactly.
Two tourniquets and then they're yellow.
Only one. Yeah, exactly. Two tourniquets, yellow. And what about the next one, the 20-year-old female? Can shove some gauze in there. But yeah, they're red right now. Yeah. And that 62-year-old male. No, not black.
That's gray.
I'd say red. They're unresponsive. They've got present carotid pulses, which means that they're in shock. Abdominal bruising with normal respirations. They're unresponsive. You can open the airway, put an airway adjunct, and they're red. You can assume there's internal bleeding, but
That's why I want gray to start, because given the extent of the situation, like what else do we have to deal with?
exactly.
By the time we get back to them, they could be a black.
Absolutely. They absolutely could. What about that 15-year-old female?
Green. Yellow. Eye is a sensitive area. Like a hand.
You could argue a red for her eye. You could also argue a yellow, just based on non-significant bleeding. But it's not just a minor injury. It's severe. She's gonna need surgery for her eye, so you can go red or yellow. It's kind of hard to say with that one. I'd personally go yellow. But it is kind of lithium rhyolite. You can go red with that too. What about the next one? The 54-year-old male.
Yellow.
Green. Yep. Hands are not involved. So that's 18% total because each arm is 9. So you've got 9, 18%. That's less than 20, and the hands are not involved. So green. What about the next one? 63-year-old female, non-ambulatory.
Black.
Yep. No pulses. 8-year-old male, non-ambulatory.
Gray. Gray.
Yep. Gray or black. So I'd go black because they're not breathing. They're not going to start breathing on their own. Just tack them black. 16-year-old female, non-ambulatory.
Yellow. Red.
Why'd you say red? That makes it yellow. Yep. They're broken. It sucks, but we're gonna go with a yellow on that one. 10-year-old male, non-ambulatory.
Gray. Gray. Gray or black.
Why'd you say that?
It's 3rd-degree burn to the chest and the back.
Yeah. What's the percentage though?
Circumferential.
Go red. Circumferential burns. We can cut that. And seriously, we actually take a scalpel and we'll do an H on the chest, and then they can breathe again. But if you look at the purely on the percentage, purely on trauma triage, they would be a red based on circumferential burns to the chest. But a 6-year-old female who's ambulatory.
Red.
But why is she confused? Head injury. Does age matter for trauma triage? No. That's why, honestly, that's why I'm putting all these ages that we're not comfortable with on here, because those are the hardest ones to triage appropriately, and it does make it uncomfortable, and it should be uncomfortable. If you were comfortable going to a 6-year-old and like, yeah, you're a red or you're a gray, making that decision, it's not fun. It's not comfortable. But we have to look at the greatest number of people, and that's where triage sucks. But yeah, she's confused, probably has a head injury. You could actually argue for a green as well because you got minor injuries. You could say she's concussed.
Probably won't die right then.
Right. Monitor. I'd monitor. 12-year-old male waving his arms.
Yellow.
Yep. Steady bleeding. 33-year-old female, non-ambulatory. Yellow. A 25-year-old male waving his arms.
Red. Red. I say red
Jeff?
because it involves a sensitive area. Involves the
Jeff?
face.
He's breathing. He's got no respiratory
Straight up,
distress.
we can see it.
Slow hemorrhage. He's yellow. 14-year-old female sitting upright.
Red.
Is it gray or is it red, Sage?
I'd say gray. At that point, then go back to
I'd say red.
slap someone.
Bleeding control sheet has to run the building.
Yeah. Control the bleeding.
If
Move.
someone's gray, can you still do intervention? Can you still
You're not.
put pressure, have her hold pressure on her neck and move on?
You could try. Like you could say, here, put pressure on your neck, but by doing that, you're basically calling her a red. You're giving her a chance of survival. Gray is, you're not going to survive. We're going to keep you comfort care. We're not really going to control a lot of things. Control the bleeding on that 14-year-old female as you're assessing her. Control the bleeding. And I'd call her a red for now. She's struggling to breathe, but why is she struggling to breathe? Well, she's got bleeding from her neck. That'd make me have a hard time breathing too. Control the bleeding, maybe she'll feel better. Maybe sit her upright. 16-year-old male, non-ambulatory. Yes. Yeah. He is still alive. He'd be a gray. Yep. Yep, he's got postal hemorrhage. 22-year-old female, ambulatory. Green, yeah. Grace Cottage loves those greens. I'll take all of them. 21-year-old male, non-ambulatory. That's what you get. Gray. Yep. 8-year-old female, waving her arms. Either way, shouldn't matter. True, but
My level, I would probably yell at them.
gray.
Gray and move on.
Yeah.
As a medic, I'd say red and deal with it, but
As an A, you can't. It's not in your scope to deal. So, and that makes sense. And that's a good point that Jason brought up too. Is if it's not in your scope, and they're going to die without a higher level intervention, it's based on current resources. So for Jason, that absolutely would be gray. They need decompression. He can't decompress them. It's nothing he can really do. So he's going to work on treating the greater good the most he can, because that patient is not going to survive with the current resources. He doesn't have decompression capability. And then the last one, 2-year-old male, non-ambulatory, second-degree burns to torso and both arms. Yellow. And one thing to think about when we're looking at these younger kids is burn percentages change. They've got bigger heads, smaller bodies, large fat chicken legs, and those percentages do change a little bit with the body size, with pediatrics and infants. So we need to keep that in mind as we're doing this triage, but rule of 9 is still a good rule to go by. How we doing? Where we're at? Yeah. Hope you guys got a lot out of it. Amanda, Ron, any questions from home? I think Amanda's the only one that's still here.
No,
Jen
I'm
logged
still
in.
here, Jeff.
we joined late.
I think it's very good.